tomorrow. How many deaths a day from COVID do you expect the peak to be this winter?
Well, I think it's very difficult to put numbers on an exact peak and when that occurs. What we can see, though, is that the R remains above 1 everywhere. The epidemic continues to grow. And if you take the 6-week forward projection, which is the part of the modelling where you're going to get greatest reliability, because obviously in any model which relies on data, theory and assumptions, the further you go out, the more unlikely it is that you get the number exactly right. But as you come nearer, you get more accuracy. And those 6-week projections, which the SPI modelling groups have been looking at for the past number of weeks, have turned out to be pretty good in terms of tracking what happens. They look as though over that period you would expect the number of deaths, perhaps if nothing changed, and that's important because things clearly are about to change, but if nothing changed, you'd expect the number of hospitalisations to breach the first wave number probably towards the end of November, and you'd expect the number of deaths to potentially equal the first wave numbers somewhere in mid-December is what they look like. So that's the sort of range that you think of in terms of the trajectory if nothing changed from where it was now.
From where it was now, so before these measures had been introduced?
Yes.
Yeah. And can you just explain how this relates to the chart that you presented that had some different curves from different research groups that there's been quite a lot of public interest in since?
Yes, so when that was presented on Saturday, what I said was those were scenarios that were put together to try to look at what a new reasonable worst case scenario might look like, and they're from a couple of weeks ago, and they are longer term modelling, so they come with all the caveats in terms of the accuracy. And what you can see is obviously there are different groups that have done those scenarios, and they've made assumptions. The assumptions they were given at that point were that the R would be between 1.3 and 1.5, that it might go up by 10% over the winter, and they modelled on that basis, and you can see the different groups came up with different peaks as a result of that. And that would be to inform a reasonable worst case scenario. And another example might be if you go back to June, the Academy of Medical Sciences did a reasonable worst case scenario for the winter, which came up with higher numbers at that point. So that curve was to then lead into the 6-week projection, which are the ones that I think carry more validity in terms of the numbers. But again, they're still a model, so you just project forward for that period, and you see that quite quickly we reach the similar sorts of numbers to first wave on those. And that's the 6-week ones are integrated across all of the models.
And so is there a consensus view in SAGE through the modelling group as to when the peak will be, assuming these new measures don't come in, and what level it will be?
So the consensus statement are the 6 weeks medium-term projections. They are consensus from all of the modelling groups taken through SPI-M, projected forward over that 6-week period. The other graph is something that would come into a reasonable worst-case scenario consensus if that's what the Civil Contingency Secretariat want, and they would commission that. So at the moment, that is not a consensus. That is independent groups having modelled against a series of assumptions.
So SAGE hasn't come to a consensus view as to what the modelling predictions would be?
For the 6 weeks, yes. Beyond that, no.
I see. And just turning to the NHS capacity, again, without the proposed measures being taken, when do you expect the acute bed capacity of the NHS to be used up through COVID patients?
Well, I may bring Chris in on this as well. Sure. Clearly, what the SPI-M group can do is model forward the epidemic. Those are then provided to the NHS, and clearly the NHS owns capacity modelling because they know what the capacity is, and we don't have the insights into the exact bed capacity. But the sorts of numbers that, if you look at where the 6 weeks take you, suggests that the first wave peak equivalent is somewhere at a national level, somewhere towards the end of November, with then greater pressure thereafter. But that won't be even across the UK. And so some hospitals are clearly under pressure now, others will be under hospital later. So again, that's an average, not expected everybody to follow that curve. But Chris, you may want to say something about that.
Well, I think it's also important that, a lot of certainly the advice I've given is not based on significant forward modelling. It's actually based on what has happened and what is observable. So if you look at the number of inpatients, and I'm just using here management information service data, but I think it's broadly accurate for England. In the 7th of September, 536 cases. By the time you get to the beginning of October, about a bit over 2,500. As of today, it's actually breached 10,000 people are in hospital. So I think you don't need too much modelling to actually tell you you're on an exponential upward curve of beds, and this is completely repeated when it comes to the ONS data, looking at the, again, this is backward-looking data, looking at incidence over time, which is the country are starting at different stages. Now, I think there are probably two things to say about your question on beds. The first is that the starting point in terms of how full they are now is currently very variable. So there are some hospitals, particularly in the north of England, which have actually now reached levels of COVID occupancy higher than they had in the first wave. And our worry there is, although in those areas it looks as if the increase in rates, the R in the community, is flattening, it has not fallen below 1 as far as we can see. It is still going up. And if they started carrying on going up from this very high base, they would get into serious trouble on inpatients very quickly. There are other bits of the country, for example in the southwest, where the rate of increase is actually faster than in the north now, and the bed capacity is lower. So although they look further away at the moment, they could hit difficulties relatively quickly. The other thing, just to be, to make an obvious point, I hope, to this committee, but I just think it's worth it for those watching, is that there are several different sort of, in a sense, barriers you go through in terms of hitting capacity in the NHS. And the first thing that we would start to have to do, and are already having to do in some areas, is actually cancelling non-urgent elective care. Then you go on to starting to impinge on urgent but non-emergency care. Then you get into the acute care being constrained, and finally into all the intensive care capacity being used up. Now that happens in sequence, but we're already seeing in parts of the country having to cancel non-urgent emergency care. And if this continues, people worry rightly about all the non-COVID care being affected. And I think the thing which the argument on this has got slightly the wrong way round. The way you prevent those services being impinged on and potentially being slowed right down, or even in some cases cancelled, is to keep the COVID rates down.
Indeed.
If you don't, then that is going to erode the NHS's capacity to do not just the COVID care, but actually the non-COVID care as well.
And specifically, the slide that one of the slides that Sir Patrick presented on Saturday, looking at projected bed usage, was that the spring peak would be exceeded without these new measures on the 20th of November, thereabouts, with extra beds that would be a few days later, and even with the extra capacity that comes from cancelling operations, that would be early in December. Does that reflect your joint view of what would happen to hospital capacity usage without these measures?
I think there is some evidence of some slowing in particularly the northeast, possibly the northwest, that might push that out in time. But until you actually start to see rates falling, it's a matter of timing, which we exactly get into for these various stages. And they say they don't happen all at once and all at the same rate at the same part everywhere in the country. But the trouble about things that start doubling is you move from very small numbers to very large numbers surprisingly quickly.
So, as is clearly the case, and it's important it's understood, you are advisors rather than decision makers. You give advice to ministers. But is it your joint view that without these measures, that there is a serious risk, to put it no stronger than that the NHS intensive care capacity would be overrun?
I should say this slide is from the NHS. So this is the NHS view of what would happen based on the SPI modelling.
Do you agree with it?
Yes.
Right. And Professor
I mean, given the caveats of
Sure.
it's a model, but I mean, yes, this is what
so
this
maybe
is
the problem
says, and it could be
as advisor, as the chief scientific advisor to the government, to the Prime Minister, your advice would be based on this modelling that there is a serious prospect of the intensive care capacity of the NHS being overrun within the period to which this graph refers.
if nothing is done. Yes.
If without these measures, which comes to the importance of the inquiries into these forecasts, because to accept that ministers decide and advisors advise, in practice, if the advice from advisors is that to the Prime Minister is that the capacity of the NHS is likely to be overrun within weeks, that is quite difficult advice to gainsay, is it not? And that's the reason why I think there's an interest in understanding the basis of the advice. It's not really optional advice in that sense, is it?
Well, I think that was the forecasting from the NHS. That's what they said, and
but it's also what you say.
It's what we say from the modelling, but it's what the NHS. I mean, as I said, we can't deal with NHS capacity. I don't have insight into the NHS capacity.
But your advice to the Prime Minister and the government, based on NHS data and the modelling data, was this is a serious prospect, is a serious risk that that's
yes.
I understand.
And I think, Chris, you'd be in the same.
Yes, serious risk, not inevitable, and the actions already being taken by people are already having an effect. But our view is, it's just a matter of time. Once the R is above 1, it'll keep on going up, and the question is only how long.
Thank you. Well, just on that, before I turn to my colleague Graham Stringham. So my question is, do these forecasts, these projections, include the impact of the tiered restrictions that began in most parts of the country on those parts that were affected on the 14th of October?
They won't yet be feeding through, in my view, fully into the numbers. But what those would do is push them out in time. They wouldn't change. So the question is not a question of whether. The question might be a question of when. Now, the only part of the country where at the moment I think there is realistic evidence that the numbers have flattened, where the R is approaching 1, is probably, in terms of regions, the northeast. There may be some smaller areas elsewhere. But it is still, as far as we can tell, still going up, albeit at a much, much lower rate. And this is the view of the local directors of public health, as well as the central view, as well as the NHS view. So this is a quite widely held view. I think that what you're indicating, and rightly, is that putting exact dates on these things is almost impossible. There's what government does. There's also how people themselves respond to the fact that they see a problem locally. And so neither Patrick nor I nor anyone who's advising government would say this is definitely going to happen on this date. And I think people who give that degree of certainty have not understood how modelling of this sort with scenario uncertainty properly works. But the inevitability that if your R remains above 1, even if it's by quite a small amount, once you've actually got to a high level of bed usage, you've got very little headroom. So quite a small R can take you from I'm just about coping to I'm not coping. And that is we're looking forward in a bad way to the fact that the most difficult time for respiratory viruses, we all know, for all respiratory viruses, is over the winter months. We haven't fully even got into them. So the chances things are likely somehow to improve without action between now and the next few months are quite low. So I think that if you're giving advice to ministers, that has to be the advice you give. Now, ministers then have to make decisions not just on that advice. They have to use multiple other things. These have big social and economic impacts, and ministers have to take into account. It's right the elected ministers make those decisions. This is one strand of advice, and I think quite strongly that it is really important that these deeply difficult societal measures fundamentally are decided by ministers.
I understand that, and the point that I've made is that if the NHS can cope and things can be accommodated, then there are decisions that ministers can make about the impact on the economy. It is, I think, much more difficult to make choices and decisions if the bottom line is that people are going to be dying in the car parks of hospitals But there's a specific issue I want to explore on this. I quite understand that specific dates are not possible to ascribe to models. It's the shape of it that counts. But given the presentation that was made and the analysis that was made that justifies action that the House of Parliament are considering this week, that information, that presentation analysis was given on the 31st of October. Surely it would be reasonable for that analysis to include an assessment of the prospective impact of measures that were decided many weeks before and indeed became operational on the 9th of October. Why is the experience of, even the prospective experience, of measures taken and implemented on the 9th of October not factored into the analysis that you shared with the country on the 31st of October?
It is, to the extent that the medium-term projections that were approved on Thursday. So they are the latest estimate from SPI-M on the medium-term projections, taking into account all of the data that they have up until that moment.
So they include an assessment of the impact of the tiered restrictions in different parts of the country?
As far as those tiered restrictions have had their impact at that point. So they were looking on that date at the data that they could have at that moment. But those data, of course, are also backward-looking. So they're not going to be able to necessarily project everything that happens as a result of changes that are not yet known.
Well, we know what those restrictions were,
yes.
And those restrictions were chosen, presumably on the basis that they were going to have an impact on the prevalence and the hospitalisation, and ultimately the deaths and the capacity usage of hospitals. So you must have an assessment of what they were likely, or let's say they hoped to achieve, and there's at least 2 weeks and perhaps a bit more of data on what they were achieving. So were they factored into the projections of the impact on the NHS that was presented on the 31st of October?
They are factored in the forward projection is the best estimate by the modelling groups of what would happen going forward,
including the impact of those tiered restrictions.
Well, if you look at the performance of the 6-week projections over the last month, the actual data has tracked very, very closely to the projections, suggesting that they are pretty good in terms of being able to look forward, taking into account what would happen. But they can't be perfect because no model ever is.
So what has been the impact, the modelled impact of these tiered restrictions that were introduced early in October? How much have they reduced the number of model deaths by, or how much, to refer to Professor Whitty's point, how far back have they pushed the prospective peak?
Shall I first go at that, Patrick? I mean, I think it is difficult to be absolutely confident about how far their effect has gone. I am confident that the Tier 2 has had an effect, and that the Tier 3 has had a bigger effect. I'm confident of that, and it's the colleagues, the community in the North and Midlands in particular, where most of these are now, obviously London for Tier 2, and some parts of the East of England as well, have responded remarkably to this, and because of that, I am confident that the rates are substantially lower than they would have been had those activities not happened. But the early indications we have at present are that this is not achieved getting the R below 1. It has brought it much closer to 1, but it is still doubling over a longer period of time. It's not possible to put an absolutely accurate fix on that, unfortunately, but we're doubling, as I've said already. We've now got hospitals already, like in Liverpool, which are above their previous peak. And it doesn't take much increase from that till you run into quite serious trouble. So the ability to actually hang on and say, well, let's wait a couple of weeks, let's just see what happens. The problem is, as you know, that the people who are in hospital now were infected several weeks ago. So there's quite a long lead time between taking an action and having an effect on reducing the number of people going into hospital, going into intensive care, and sadly in some cases dying. And therefore, if you wait too long, you've baked in a very large backlog of things where the rates are still going up, and we do not have, in my view, clear evidence at this point that R is below 1 in anywhere that we actually have significantly high rates, and that's a reality which I think my NHS colleagues in the north of England would say they recognise.
I understand that lagged effect, obviously, on admissions and ultimately deaths, but it is the case in Liverpool, for example, which you cited, that the peak level of positive tests was around the time of the imposition of Tier 3, around the 9th of October, at about 3,500 positive tests a day, and that's the 7-day rolling average. The most recent 7-day rolling average, and it's come down consistently since that peak, is about 1,900, so falling towards about half that rate. So does that indicate, in your view, that the Tier 3 restrictions are working, and has that been fully captured in the modelling that is being put forward to justify the new national restrictions?
So, looking at the data, particularly in the north of England, and I tend to look backward at data rather than, I find more than quite short forward projections for exactly the reasons you're giving, Chair. I'm very cautious of. I'm much more interested in how the data is playing out in real time and immediate past, and therefore the immediate future. And what we are seeing is that the rates, particularly in younger people, have fallen, and that's some combination of probably some slight reduction in uptake, but also some levelling off and possibly reduction in positivity rates. So I think there's a real effect and an artificial effect, if you see what I mean. But we are not seeing that reliably in the older age bands as it's moved up through the age bands. And that's important because actually the rates falling in people in their 20s will actually have remarkably little impact on the NHS. A few people in their 20s get into serious trouble. More obviously may have long-term morbidity problems, not necessarily getting into hospital, but the group of syndromes which are currently called long COVID. But the rates are still steadily tracking up in all the data that I have seen in the older age groups, who are the ones who are likely to translate into hospitalisations, ICU cases and deaths. So I think it would be would require a really extraordinary degree of confidence that the overall data were translating through to say these isn't still going up in the age groups who are most vulnerable to having severe outcomes and ending up in hospital and in some cases having very bad outcomes. So it's that age differential which I don't think is necessarily captured in the headline figures, and I think that people who aren't spending their entire time looking at hundreds of pages of data see the headline and they think, well, it's going down, and that's reassuring, not necessarily going down overall, but the rate of increase is going down. But there is this quite marked age differential, whereas it's the younger adults where the reduction is most marked.
So you think that the fall in positive tests in places like Liverpool, quite marked fall over the last few weeks, is not reflected in the prevalence amongst older people?
Correct. This is a differential effect amongst different ages. Now, my hope is that it is now levelling off in the older ages as well, and I think there's some evidence that may be beginning to happen. But it's certainly not to the point where you could reliably say, well, just, I know the models show this, but actually I think it may be going lower than that, because actually that isn't what we are seeing in these older age groups. I would be delighted, obviously, if the answer was they were going down faster than the data currently are showing. And there's always a bit of a data lag, and if that was the case, that would be very good news. But I think it would be very imprudent to work on that basis.
So the implication of that is that these local lockdowns, the tiered measures, are not working for older people?
I think the implication is that with all the tiering, I think they have slowed things down from where they would have been otherwise. I think that would be my judgment as to where we are, and more in Tier 2 than in Tier 1, and more in Tier 3 than in Tier 2. And that's due to remarkable work of individuals taking really quite difficult social decisions for quite prolonged periods in many of the towns of the north. And I think we should not forget how long some of them have been in these measures. But there is no evidence, in my view, at this point, that in the older age groups, the R is now reliably falling below 1. It may be in some places approaching 1, and therefore the doubling time is going out in time. That is not the same as the doubling time turning to a halving time, which is what you want to see.
Thank you. It's precisely for that reason, Professor Whitty, for people that have suffered restrictions for a long period of time, they, I think, would want to be reassured that their experience has been reflected in the model and that we're not justifying a national lockdown without reference to the experience that they have on behalf of the country gone through. Would you publish the model, the NHS capacity usage model that lays behind these figures? Because it is such a pivotal one for the measures that are taken.
Well, the data that I was talking about were not NHS data. Those were the JVC test and trace data. They're not my data, but I don't see any reason why anyone would not want to publish data of this.
Would you write to the committee in the next few days with the details?
Well, as I say, it's not my data to release, but from my point of view, it should be openly available. And almost all of the key headlines are openly available in almost all areas through PhD and other routes.
You're the Chief Medical Officer. I think you're a man of influence. I'm sure.
All I'm just doing is I'm trying to avoid promising something which I can't guarantee to deliver. I'm pretty confident I can, and I want to, because I wish people to see. I'm very strongly in favour of people seeing the data. I'm very strongly in favour of it.
Grimsby.
Just following up on the point you were making about infections increasing in elderly, more vulnerable people, which is the key criterion? Is it the R figure, or is it the rate of infection in elderly people?
Well, the rate of infection in elderly people, the number of people infected, tells you what is going to happen in terms of in a small proportion, but an important, because the total numbers are very large, a significant number of people having severe effects. That's the strongest predictor of what will happen in the NHS is what has happened in people over the age of 60, for the sake of argument. Actually, of course, it's much greater in those in their 70s and much greater again in those in their 80s. It's not a cut-off, it's a kind of log linear curve. But the R is giving you a sense of is this doubling if R is above 1, or is this halving if R is below 1? And at this point in time, all around England, R is either above 1 or tending towards 1, but not falling at this point overall. And that's the figure that comes out of SPI-M. Patrick's in a better position to talk about that. But the R is a kind of summary figure. But actually, what you can see is it's either rising or it's falling, and that's the key question. The R, in a sense, is a reflection of that.
I understand that the R is a composite figure, and what I'm really asking is if, just to give a hypothetical example, if R is at 0.8 or 0.75, but there are a lot of infections amongst elderly people and hospitalisations, which is the key factor in your recommendation?
So in the immediate term, the number of people currently infected is the key thing. But the R will tell you that actually you've got this number of infections now, but if it was 0.8, I would be delighted if it was 0.8, and that would tell me that if I look forward 2 weeks, 3 weeks, 4 weeks, the numbers of people who are newly incident cases would be going down. We'd be back to a situation where the numbers were halving rather than doubling. But currently, as I say, they are doubling in most places.
So Patrick, Professor Whitty said before, for anybody familiar with modelling, it was clear what was going on. The vast majority of people in this country are not familiar with modelling. I think it's fair to say that. Was it sensible or fair to put forward the graph with 4,000 deaths a day with or without the caveats? Pictures tell a much more powerful story than numbers do. That would have frightened a lot of people around the country. Wouldn't it have been better both to give the source data on that and explain in great detail, not just that it was modelling, but that the figures that had gone into it were 6 weeks old?
Well, I think I positioned that, and if that didn't come across, then I regret that, but I positioned that as a scenario from a couple of weeks ago based on an assumption to try and get a new reasonable worst case scenario, and that those figures therefore were not as reliable as the 6-week figure which I spent time talking about. So those figures were ones done by major academic groups based on those assumptions, and in the spirit of trying to make sure that things are shared and open, they are the things that we have seen, and it's important that I think people see that.
Well, I don't think people see that. Certainly if you look in both the serious broadsheet press and the more popular tabloid press, people have been horrified at the way that was presented, thought it was a biased way of presenting it, and not at all clear. You must realise that if you put a graph up saying 4,000 deaths a day, that is going to be the message that the vast majority of people take home. Do you regret that at all?
Well, I think the aim of the presentation was to try and get as much of the information as we could out there. The 6-week projections were the ones that are important, I think, in terms of their reliability. Those were models for the reasonable worst case scenario, and the reasonable worst case scenario is something that people have been interested in, and they were modelled at the time to try and project that. And they came from very significant academic groups, and they are no more than a model of the reasonable worst case scenario based upon assumptions. And the further models go out, the more unreliable the numbers are, and the more it becomes a qualitative exercise to look at the shape of things. And I think it's important that people understand and see what that is being looked at by the modelers, who believe that these things are important to have in the reasonable worst case scenario.
You don't think that you just frighten people who do not have your scientific background and understanding of models and not...
Well, I hope not. I mean, I think I hope not, and that's certainly not the aim. And I will say that in a sense, we went through this a bit on the 20th or 21st of September when we said that we thought that things could be headed towards 50,000 cases per day if we had a doubling. Again, it was a scenario, not a prediction, and that deaths might reach 200. And the same argument that was somehow there to scare people was put to those slides. It wasn't there. It was there to sort of give a scenario. As it happens, the numbers turned out to be very close to that by the time we got there. So it's very difficult to project forward in a way that doesn't inevitably lead to a problem of, is that real? No, it's not real. It's a model, but it is what we need to understand, because this is a disease which is spreading, like all epidemics, in a way that will affect us in weeks to come, but isn't felt today. And I think there's that balance between trying to explain what may be coming, basing things, as Chris has said, as far as possible on what data you have today, which again is why things were presented as they were, to say, here are data from today and what's happening in hospitals today, but giving illustration of what may happen in the future, I think is an important part of this, because the tendency otherwise is to wait and to say, well, we'll find out in a few weeks' time, by which time you've baked in another 3 or 4 weeks of cases.
It seems to me there are 2 reasons for having a lockdown. One is to save lives, and the other one is to buy time so that you can improve test and trace in other parts of the service. In terms of your recommendations, you're very clear in your models, the information you've provided in the models, what numbers you want to present to the Prime Minister and to the public. You always put the caveat on there are economic consequences and health impacts that happens, but that's never quantified. Now, last time you were here, you told us about the paper on April the 8th, which was a quantification of some of the deaths that will be caused by the failure to treat cancer. I'm not going to go through the full list, and the consequences of poverty on mortality, on morbidity. Why do you not present both sides of the equation in numbers?
Well, I'll have a go at it, and then Chris may want to come in. So the paper you referred to was a paper that we asked to come forward from ONS, actuaries and others to try to look at the overall effect. And I think that was a very important paper, and that is being updated, actually.
And the Department of Health and Public Health England.
So that is being updated, and Chris may want to say more about that. It's very clear that SAGE is there to provide the science advice, and the Treasury and Cabinet Office are there to bring in the other parts of the equation, particularly on the economy. And I don't think it's right to think that SAGE would be the place that you integrate all of this and come out with a single number. I mean, we have a particular part of this to look after, and the rest needs to be integrated at Cabinet Office level, and of course ultimately ministers need to look at all of those other points. And it is an interesting question. The science advice is very clearly in the public domain. It's very clearly public, and you can see it and you can question it. And the other advice, of course, is less visible. So it's more difficult to ask those questions.
But the advice is sort of lopsided, isn't it? I mean, that paper, that I'd be interested in seeing the updated paper of April the 8th, I think from memory, projected over 200,000 deaths over a period, not over a year, but over a period of time. I think the public would be very surprised to see that was the other side of the equation. And at the very least, I can accept that you need economists to do it and all sorts of other specialists, but don't you feel a responsibility to make sure people know there is another side to that equation?
Could I add something, Sir John? Because I think there's a danger that people watching this, which I realise you don't, will have a misapprehension. Most of the additional deaths stack up because you don't deal with COVID. So basically there are 4 different ways in which this causes mortality, and I'm going to go through them. I realise that this, but I think this is a really critical point which has been wholly misunderstood in some areas. There's the direct deaths from COVID. That's easy to understand.
Yeah.
I agree with that. The second group, which hopefully we will not get to, are deaths from emergency services being overwhelmed. We did not have that in the first wave, and we have every intention of trying to avoid that in the second wave. But the third group is things which happen because of COVID putting pressure on the service. You have to cancel elective, cancel urgent, other care. Those are the deaths like in the urgent care, that might be cardiovascular. In the medium term, that might be cancer. Those are actually on the COVID side of the equation. And then you've got some which are around the lockdown itself, which are things like reduction in air pollution on the bad side, on the good side, and increase in mental health problems on the bad side. And then at the final ones, which is the very, very important, are the economic ones, which counterintuitively, the immediate effect is actually not negative, but in the long term, that is very, very important. And that's the bit which is on the other side of the equation. And I've always said that really clearly. If you're in public health, caring about increasing deprivation is central to what you do. It is absolutely critical. And that bit, absolutely, I've always tried to say that is the other side of the equation. But all the cancer deaths, the cardiovascular ones, they're in fact on the COVID side, that if you don't deal with COVID, those are going to get worse.
I'm running out of time, but one could argue, I understand the point you're making, that because of the pressure of COVID, some of those services are reduced. But some of those services were reduced because service withdrawn, not directly because of COVID. So it's a more complicated equation on that. But my point to Sir Patrick was, shouldn't that somewhere in the system be put together, whichever side of the equation you put it on, and will you do that?
Well, again, I think you're right. It needs to come together. It needs to come together with the economic analysis. And that isn't something that takes place in SAGE, nor should it take place in SAGE. It needs to come together in Cabinet Office.
So you've been very good in publishing, at the request of the committee and others, the papers and the evidence that SAGE has considered. There's a bit of a time lag there. I think this week shows that it would be good to have the real-time information. But can you arrange for that economic analysis to be published in the same way?
No, I can't.
Whose decision is that?
I think that's one that you would need to take up with ministers and Cabinet Office.
All right, thank you. Thank you. Just one other question of publication. You mentioned several times the reasonable worst case scenario. That, as I understand it, has been leaked rather than published. You can, I think, commit to publish that on a regular basis.
No, it's not our document to publish. That's the Civil Contingency Secretariat.
Do you think that should be published?
I think there's an advantage in having as much published as possible.
I'm going to be riders with that, actually. It's exactly the point Mr. Stringer was making, which I actually agree with, which is there is a danger with these extreme forward projections that people then misinterpret them as this is what's going to happen, and, as you say, get unduly worried by something which is not intended to happen. The whole point of a reasonable scenario is to say, right, that we need to do something, we're going to stop this happening. So I do think that I can understand why our colleagues from Civil Contingency Secretariat would pause. I'm personally in favour of publishing as much as possible, but I just wanted to, in a sense, reflect back the point that Mr. Stringer was making, which I think has some force and has to be balanced against it by civil service.
Andrew Griffith, and then Jeremy Hunt, and then Dawn Butler.
Sir Patrick, good afternoon. Sorry for the slightly forensic tone, but these are very grave matters. They're some of the most grave matters that we as members of Parliament are ever called to vote on. So I want to stay with slide 3, which is one of those you presented on Sunday, the one that's called winter scenarios. And when you look at that blue line is a clear outlier. Its peak is almost double the level of the next highest scenario. And the other 3 scenarios all have their own peak forecasts lying within a range of about 20% of each other. So it really is very different in terms of the slide that you present. If you didn't have that blue line, for example, you'd have to change the scale. So at the time you presented that data to the Prime Minister, did you yourself understand the assumptions behind the blue line that we now know is the Public Health England Cambridge model?
Well, I think what we try to do when we present data from SAGE is to look at the integrated SPI-M output. And that is the 6-week ones, and in due course would be an integrated, reasonable worst-case scenario. That slide is of independent groups and what they have modelled. And as you can see, there's a lot of variability in that slide, with most of the groups coming out on the right-hand side and one being left and higher. And clearly that is an outlier for the reasons of the way in which they've done their model and assumptions. And I think that is the reason why we tend to go for integrated views from SPI-M, not to go with individual group projections.
Do you know what it is in those assumptions that produces that very different shape to that curve?
Well, the assumptions underlying the models will be published in full, and so it'll be possible to look at the reasons why curves differ.
Are they in the public domain now, before the vote that we have to make tomorrow?
The intention is to get the information on the models out, I think, as soon as possible. I don't know exactly when that's coming out, but very soon, I think.
It would have to be today if it's true.
Yeah, I think there are some documents coming out today if we can get them out today. I mean, they're not ours, so they would need to come out from the groups.
I understand that, and it would certainly be very helpful, I think, to colleagues if it was. I mean, when you looked at that chart, I mean, it forecast more than 4,000 deaths a day at peak, which is, I don't think any country in the world has seen that rate of deaths. But also, if you then bring it back to today and the time that you were presenting that to the Prime Minister and his advisors, I mean, it would already have been off the curve. I mean, it would already have been predicting around 1,000 deaths a day at this particular moment in time. And can you just remind me how many deaths there were yesterday?
I can't remember the exact figure. It was 138 or 100. Do you have the exact figure?
Mondays are always artificially
low.
Today will be artificially higher for the same reason. I wouldn't concentrate on individual days.
What we have done is looked at the initial portion of those curves in relation to the data and indeed in relation to the 6-week forecast as well. And what you see is that the initial portion of those curves for the other projections are there or thereabouts for 2 of them and higher than the real data for 2 of them. And ultimately, of course, data trumps models.
So sitting here today, I agree with that. But sitting here today, then, with the ability of that data, would your advice be to colleagues to essentially discard that model, to accept that it's somewhat discredited, and that we should set that aside when thinking about whether this is the right course of action?
Well, I don't think it's at all fair to say it's discredited. These are scenarios that were put together on assumptions to look at what a reasonable worst case scenario might be. And as Chris has said, a reasonable worst case scenario is something that you do not want to happen, but is something that could plausibly happen if things went in a certain direction. I think the right graphs to focus on in terms of forward projection are the 6-week medium-term projections. They've been shown to be relatively good over the past 4 weeks. You'd expect them to project forward. And again, they're assuming nothing changes going forward, and things may well change, as you know. And to base it also on the data we have today, as Chris has said, which shows where things are in hospitals at the moment, which are filling up. And I think these are not forecasts. These are models which tell you how things can look. But they are not forecasts, and they should be looked at knowing that.
Would you like me to just add? Would you like me to add just one comment on that?
Chris Whitty.
I think that if there is someone whose feeling is that the difference between them being supportive of these very restrictive and difficult measures is the difference between 1,000 deaths a day and 4,000 deaths a day, if that is the case, and remembering that if there were 1,000 deaths a day, that would imply significant pressure on multiple other bits of the NHS, this, I think, becomes a very material question. But I think all of us would say that the rates would probably be lower than that top peak. But I think the reaching the peak which we reached in April strikes me as an entirely realistic situation. So if people wish to take a conservative view, I mean that in a small c sense, that would be something which the short-term projections would take us to.
Andrew?
Very helpful. No, thank you. That's very clear.
Thank you. There is a particular relevance to that statistic, though, is there not, Professor Whitty, in that the NHS did cope with the peak last time, and one must assume that we've made further improvements during the summer. And so a whole set of other choices are possible if the NHS is not going to be overwhelmed. So the difference between 1,000 and 4,000 is actually quite material.
Yes, and I have to say I feel slightly uncomfortable implying that this is a decision for me as a doctor advising government to decide on 1,000 or 4,000. This is, actually all I'm saying in response to this question is, I think there's been some rather overblown rhetoric on this. People can take different projections if they wish, but getting to the stage we got to in April, and if we do nothing, carrying on up from there is entirely realistic.
Okay, thank you. Jeremy Hunt, and then Dawn Butler, and then Aaron Bell.
Thank you very much, Chair. I just want to pick up on what Professor Whitty has just said. I mean, talking about 4,000 deaths wasn't overblown rhetoric. There was actually some slides that were presented to the public. But if I just take your conservative view, as you said, that it's not at all unreasonable to say that we will reach the same level of deaths as in the first peak. Many people would find that very curious. We now have dexamethasone. We are much better at knowing when we need to transfer people into ICUs. We understand about when to use ventilators and when not to. Testing is much better. We're monitoring people who have the disease, finding out about them much earlier. We've had more time the whole of the summer to plan for capacity. So why is it, I think a lot of people are very curious as to think why it is that we are likely to be seeing, if we take no action, the same level of deaths as we had in the spring.
Well, I think that the points you make about the reduction in mortality that we'll get with some of these interventions is important. Dexamethasone, which I think the UK can feel proud that this was something that we did for the whole world very fast, will reduce mortality. There is less use of ventilators, which I think looks as better. There are a number of other medical improvements. But these are going to reduce the mortality. They are not going to take it right the way down, unfortunately. So, for some people, sadly, will come into hospital and whatever you do, they will die. And I think the idea that there's been a huge transformation in the infection mortality rate would not be supported by the current data. There has been a reduction. I'm confident of that. There might have been a halving. I think it's difficult to tell currently on the current data. Let us hope that is the case. But what we're seeing at the moment is numbers of deaths are going up really relatively steadily over the last 2 or 3 weeks. I don't think, given that this is an exponential curve, the idea that this could get from the mid-200s to the 1,000 mark over a number of weeks does not strike me as a particularly strong thing to be saying, actually.
No, I think that sounds very sensible. I just don't really understand why, because you just said it may be that the infection mortality rate has halved. It's certainly come down. So I'm just curious as to why it is that we should be looking at the likely prospect of deaths reaching the same daily level as the previous peak.
Because when you've got a doubling incidence, all you've got to do is give it one doubling time, and even if the mortality is half that, you're still at the same number.
Okay. And if you look at the 6-week projections, and you look back over the last month, actually the deaths have tracked the projections, so that's taken into account in those projections. And I don't think the infection fatality rate has necessarily halved. I think the in-hospital mortality rate has gone down.
No, to be clear, I think my halving was that's the best we can hope for. I think it is probably less than that, actually. I want to be clear about that. Thanks, Patrick.
Okay, thank you very much. I just wanted to follow up what the questions that Graham Stringer was asking to the Chief Scientific Advisor about the two graphs. So you showed one graph which was scenarios. You're very clear it's not predictions or forecasts, which showed that deaths would be 2 to 4 times higher than the first wave peak. That was slide 3. The very next slide you showed, slide 4, was the England Daily Hospital Admissions SPI-M medium-term projection. And that showed those hospital admissions going up, not doubling or not tripling or quadrupling, but going up by 25% approximately. That was the medium-term projection. Is that not very confusing to show 2 slides consecutively, one about deaths, suggesting we could see 2 to 4 times the number of deaths, and another about hospital admissions, showing a projection of it just going up by 25%?
Well, they were very different timelines. I mean, clearly one is a longer-term modelling scenario, and the other is a shorter-term projection. And actually, the shorter-term projections are rather similar to the upswing of some of the other curves at the very, very base of those curves.
I'm just looking at, sorry, Sir Patrick, the slide 3, the winter scenario, shows those deaths peaking around the end of December, and the hospital admissions rate is showing that for the week of the 8th of December. So there might be a difference of a week or so, but it's not a massive difference in the timeline, is it?
No, the key thing, and again, if this is confusing, then I apologise for that, but the model projections of the 6 weeks were the things that I was clear that's what you need to concentrate on. Those are the things that you can have more reliability on in terms of the numbers. The others were scenarios for reasonable worst case planning, making an assumption around what the R would be and making an assumption the R may increase over the winter. The projections are a forward look over the next 6 weeks with a greater degree of reliability, but again, there's still a model, and they show in the hospital admissions that you quite quickly would get, under these projections, to a hospital level above the first wave peak, somewhere towards the end of November, about 3,000, and in the deaths move up towards several hundred by early December. And as CMO has just said, with a doubling, and it depends on the doubling rate, that can increase very quickly, depending on what the doubling rate is at that point. And the whole aim, of course, is to make sure that not only the doubling rate goes out much further, but ideally it becomes a halving rate, and that's what you would want to do in order to get these down.
So Professor David Spiegelhalter said today about presenting that slide 3, the slide which talked about the winter scenarios and the potential quadrupling of the death rate. He said, I was very unimpressed. I was disappointed that graph was shown. Now, I know Professor Whitty has previously praised Professor Spiegelhalter for his insights into how to use statistics. Does he have a point?
Well, I am second to none in my admiration for David Spiegelhalter, and I would reiterate that I think the 2 graphs which are important are the 6-week projection ones.
Okay.
Can I be clear?
Yes, of course.
Can I be clear that I have never used anything beyond 6 weeks in anything I've ever said to any minister on this issue, for that reason?
Okay, I understand that, but I'm just curious that you haven't used it with any minister, but you were prepared to jointly present it to the public at a very, very important press conference on Saturday afternoon, on a day when the Prime Minister made a complete about-turn in his policy. And so it wasn't important enough or reliable enough to present to ministers. I'm just surprised that you both decided it was important or reliable enough to present to the public.
That graph had also been presented to the Prime Minister.
So he had seen projections beyond 6 week projections then?
Yes.
Okay. A quick question to Professor Whitty, and then I'm finished, Chair. I just wanted to ask you about the role of test and tracing as we go forward. And you will know the latest figures that we only actually reach about a third of the total number of those who've been infected when you take into account the ONS projections of the daily numbers being infected. And probably less than a quarter of those being asked to isolate are actually isolating. And this led SAGE to say on the 21st of September that this system is having a marginal impact, only a marginal impact on transmission. Now you chair SAGE. Is that your view about NHS test and trace?
Well, I mean, let me just start off with the figures you started off with. I think that test and trace have gone from a standing start to actually a really, a long way down the track. But there are two buts to this. The first of which is once you've got very high rates, as we have in many parts of England now, we've all said from the beginning that this is most effective when the rates are low. And so one of the reasons why getting rates low is a very good thing is it gives test and trace a much stronger ability to actually get things to have a much higher proportion of people picked up. In terms of the numbers you quoted, I think there's probably two caveats to the data you've just talked about. The first of which is you would only expect test and trace to pick up symptomatic people. The ONS data also picks up asymptomatic, so I think you don't set them a completely infeasible target. And the second is, I think some of the commentary on this, including the academic commentary, implies that if someone has been contacted and doesn't follow exactly every single element of an isolation thing, they're doing nothing. So they give it an all or not a 1-0 kind of approach. Actually, a lot of people may well be actually responding to being contacted by changing behaviour very substantially in a way that reduces transmission, but it isn't an exact replica of what's expected. I'm not disagreeing with you. All I'm just doing is I'm just finessing slightly an understanding of the numbers you just given.
Yes, perhaps you could just explain that though, because as I understand it, what the contact tracing element of test and trace does is it contacts people who've been a close contact of someone who is confirmed as positive and asks them to isolate. So it is contacting people who are potentially asymptomatic transmitters of the disease, and that's why you get overall a rather low number. Is that not correct?
No. So the point about the picking people up is its entry point, the first point, the person it picks up, the index case, they do it on the basis of symptoms. This person has gone in for a test based on symptoms.
I understand, but then they contact the close contacts.
Yes, but that it's the index case you're judging them against in terms of the ONS stuff. That's the correct denominator in a sense.
Yes, but we're still only asking to isolate a low proportion of the people who are potentially transmitting the disease. Anyway, what you're really saying is that you don't disagree with what SAGE said, that it is only having a marginal impact on transmission, but the reason for that is because we have such high levels of transmission. And do you think test and trace is really likely to be more effective when you have lower levels of transmission? I think what you're saying?
Yeah, even under optimal conditions, it'll do a lot better with much lower incidence. So, all other things being equal, which that's a big if, but all other things being equal, it'll actually probably now be having a bigger effect, if anything, in the areas which are slightly lower in incidence than in the higher incidence areas. That's what most modelling on this area would imply.
Thank you.
And you'd expect it to be more effective, and you can see across
Europe that that's the case as well, that even very effective test and trace systems do not work well at high prevalence.
So secondary gain of reducing the incidence due to what the Prime Minister has announced if it's voted through by Parliament, is that it will bring the numbers down to the rate where actually this becomes a bit much bigger part of the solution. But, we need to be really clear, even under perfect conditions, test and trace only takes a proportion of the R. It's not, you can do that and you forget everything else. It's a proportion, and that's all we can reasonably expect of it.
Thank you. Just on that point, the paper that Jeremy Hunt quoted from, that the SAGE paper, that the system's having a marginal impact on transition at the moment, that was the paper of the 21st of September, when prevalence was much lower than it is now. So even in those conditions, the verdict of SAGE was that it was having a marginal impact. So what assessment have you made in your models of the contribution that test and trace is making? Perhaps Sir Patrick.
I can't give you the exact proportion. It varies from model to model as to what people will have taken on that.
You're looking ahead. You're familiar with the plans of test and trace. Are you modelling it with an expectation that is going to make an appreciable impact?
There's a paper, I think, from June, which looks at exactly this question as to what the impact of different levels of effectiveness of test and trace is on the overall ability to control R, and what other measures you'd have to have in place depending on that. So that paper lays that out.
But going back to our earlier discussion, in terms of making sure that your projections, your modelling for the next 6 weeks takes account of all of the relevant information, have you assumed that test and trace is going to make an impact on transmission over the next 6 weeks?
I can't tell you exactly what's in each of the models, but it will not be an assumption that there is a big impact of test and trace at current levels of prevalence.
I understand. Thanks. Dawn Butler.
Thank you, Chair. It's a known fact that lockdown buys us time, but it is in no way a solution to anything. And what we have to do is focus on actions. And I think, Sir Patrick and Professor Whitty, that you're both contradicting yourself when it comes to testing and tracing and isolating. And let me just explain what I mean. So you've spoken a lot about the R rate and trying to get the R rate below 1. Well, we know that once you start testing people, if you don't get the results back within 24 to 72 hours, that has an effect on the R rate. So you can't talk about the R rate without talking about the effect in testing and getting the results back on time. Am I correct in my thinking, or am I wrong in my thinking?
Well, I think you're probably bringing together two separate important points. The first one is you are absolutely right that to reduce R, test and trace systems need to get the results back as fast as possible. The faster they do, the bigger the effect on R. That's a critical part of it. And actually, one of the reasons that I, amongst others, am keen not to always have test and trace being asked to do yet more things is this shortening of the time is a critical part of it. But the calculation of R does not itself depend on the length of time. That depends on the number of incident cases over over a period of time. So I think the point you make is a perfectly reasonable one, but it doesn't affect the R in the terms of how you calculate it. But we must try and reduce those times because that's how test and trace has its biggest impact.
Okay, so in the short time, thank you for that. So in the short time, it will have an effect because you'll know the infection rate. Now, as we know, in the summer when we went into national lockdown, there was around 100,000 people showing symptoms of COVID. During the winter, that number will rise exponentially to 500,000 people a day will show symptoms of COVID. They may have COVID, they may have flu, they may have something else. So that therefore surely means we need to ramp up our testing capacity to 500,000 tests a day. How close are we to achieving that?
Well, I'm very cautious about getting into the business of trying to kind of say what proportion of tests are. There's tests available, there's tests done on individual people. They're all slightly different calculations. But the capacity to do testing for people who are symptomatic is substantially greater now than it was at the beginning of this month. But I'm not going to put an exact number on it because I'm not the right person to answer that question.
Who is the right person to answer?
Test and trace are the people who actually have the data on that.
The Dido Harding. So are you in any way discussions with them? Do you in any way know how close we are to achieving what we actually need in order for you to be able to model correctly in regards to what we need going into winter? Because I'm sure you're aware of the frustration of the public. You have both said previously that in order for us to combat and control the virus, we need the public to comply. Now, as you know, the public are very frustrated. These questions are important for the public to understand what is going on and why. So what, in your estimation, how close do you think we are to achieving the capacity that we need? And not the capacity, because you can say capacity means nothing. We need to know numbers. 500,000 people will have COVID-like tests every day. How close are we to achieving that in regards to testing?
So I think what I'm going to, I'm trying to answer your question. I hope helpfully. There's varying indications for testing, and the point you're making completely rightly is that as we go into winter and autumn, we're likely to have more people who have symptoms compatible with COVID who don't have COVID, but who still need to be tested. I hope I'm paraphrasing you correctly. And part of the key reason to increase capacity for test and trace, in my opinion, has been exactly to achieve the point that you've just raised. But there are obviously, and so, my hope and expectation actually is that test and trace will have the capacity to test people who are symptomatic through the winter period. That is my expectation. There are also some very clear indications that I think everybody agrees on in terms of other uses. There's clinical uses in hospital, obviously, there's testing in care homes and a variety of other indications. But there's also a lot of additional things which people think of which could be used for testing could be used for, which include, as you know, there was an asymptomatic mass testing pilot launched yesterday in Liverpool. There are people talking about doing much more widespread testing of health and social care workers, and Mr. Hunt on the Health and Safety Committee has made a very strong right point on this, and so on. It depends really what the denominator is you're talking about. But in terms of the people who got symptoms, my expectation is that test and trace, who have, as I say, done a really good job in this area, should have the capacity in terms of numbers of tests to be able to do that.
Thank you. Professor Whitty, you have said in February that SAGE recommended that there was an increase in testing, and we also know that testing people as symptomatic just isn't good enough, because we've been told by SAGE if we only test people who are symptomatic, we miss 70% of people who actually have the virus. But I'll just ask you another question. Did shielding, in the summer when we went into national lockdown, did the shielding of vulnerable people help to save lives?
I think what we thought, so we haven't had a really clear answer to, there were definite benefits and definite disbenefits of shielding. The benefits were reducing the risk that people got COVID. The downside, but the trouble about that is there wasn't a denominator, because you took all the people who were at risk out into the shielding group. The downsides of it were also clear, which was an increase of loneliness, an increase of, in some cases, probably mental health issues and so on. And trying to work out the balance between those, our impressionistic view is that shielding was useful, but should be a less strict version of shielding in the next phase. To allow people a little bit more, particularly time outdoors and so on, because actually there was this real worry that people were feeling trapped in their houses and all the downsides that went with that. So there has been an adaptation of that, and we're also intending to change over time the group of people who are in the shielding list, and there's been something published in the BMJ a couple of weeks ago which explains how we're going to do that, because the exact risk factors that led to the shielding list were generated at a stage we understood much less about COVID than we do now. We still are learning a huge amount more, and we will know more in another 6 months, but at the moment we think we can actually change that, the biggest change being quite a much very high proportion of the children who are shielded. The view was the risk is not sufficient to justify the significant downsides on that, but there have been other important changes with the shielding, so it's an important question you've asked.
Thank you. We're more than halfway through our session, so I think we'll all need to keep questions and answers more succinct. I'll come back to Dawn if we have chance, but I want to turn now to Chris Clarkson, then Erin Bell.
Thank you very much, Chair. Thank you for appearing today, gentlemen. I just want to go back to the testing, in particular to PCR testing. I want to understand at what rate have you accounted for false positives and false negatives in your modelling, and what are those rates?
Yes, I'm not sure I can give you an exact answer on that. I mean, PCR really doesn't have much in the way of false negatives apart from swab negatives. I mean, it's very sensitive, picks up lots of things, even can pick up very small amounts of RNA, which is one of the reasons that it probably picks up people who aren't actually infectious. It picks up people who've got some residual RNA from having a virus. So in that sense, it's a false positive in terms of the infectiousness. But I mean, PCR is extremely sensitive and doesn't, as I say, apart from swab failures, doesn't really have a big false negative in that way. And I'm not sure it'd make a big difference to any of the modelling assumptions.
So if I can just add one additional thing to that, which is, in terms of the ONS data, which is the gold standard, they have a really good technical series of slides on that, how they've made their estimation on PCR, which I think is probably the best way to look at that. It's quite a technical area. The point I'd make as an epidemiologist, though, is the key metric is actually not the sensitivity and specificity, although that's important. It's a positive and negative predictive value, which varies by point prevalence at a point in time. And in fact, the testings on those will become more accurate, depressingly, as the prevalence rates go up. So that the risk of a false positive is higher when the rates are actually lower.
And the risk of false negatives?
The converse is true, but we're at sufficiently low levels, it makes much less difference about that.
So if you had to put a figure on it?
On false negatives?
Yeah.
Well, it depends what use you're using it for, basically. Is it a clinical use or is it an epidemiological sampling use? So the epidemiological sampling use, I would refer you to the ONS data because I think there's a really good technical document on that. For clinical use, what you're really wanting to do is pick up those people who've got symptoms that are important enough to actually want to do something about it. And I think the big risk there is actually about sample acquisition more than it is about the actual lab side of it. The lab side of it's pretty good. But do you do swabs properly? And that's one of the reasons that I'm very keen, for example, that we're moving, particularly for things like social care and NHS staff testing over towards saliva testing, because that has a much lower difference if we can get it right in terms of sample acquisition.
Thank you. Would you be able to make that ONS document available to us?
It's public.
It's public. It's a public document, but I can point you in the direction of it.
Perfect, thank you.
Thank you, Chris. I'm going to come now to Darren Jones because he's got to leave the committee for another engagement. So, Darren.
Chairman, thank you for the invitation to be with you, and apologies to colleagues on the committee for bumping up the list there. Professor Whitty, is it right to assume that there are health implications associated with the economic consequences of decisions around tiered regions and a national lockdown?
Yes.
And Sir Patrick, earlier you said that it was inappropriate for Treasury officials or economists to be on SAGE. Why do you think that in that context?
Oh, we have got somebody from Treasury on SAGE. I'm sorry if I made you think we haven't. We have got somebody on Treasury. What I said was that I think it's inappropriate for SAGE to be the place where all the economic advice gets integrated with the health advice. We do indeed, and Chris has said this many times, and I have too, that the health impact of lockdown and other measures is something that we think about very carefully, and we're very aware there are impacts. And the paper that's been referred to already from June from the ONS actuaries and DHSC, which is being updated, looks at that in great detail.
I'm interested to understand the depth of the economic assessment, because in the minutes from SAGE, I looked at the last set of minutes, for example, and searched for the word economic, and it only came up saying excluding economic impact. So
Yeah.
how much time or input do you have at SAGE around the economic consequences of these decisions?
No, we don't. And again, I'll come back to that. That's not the role of SAGE. And we've been very clearly instructed that the economic impact of this is something that sits in HMT, and they look at the economic impact. So we do not look at the economic impacts, and we are not mandated to look at the economic impacts.
But can I add one thing to that, though, which is it is very important that the economic colleagues also understand the epidemiology. So I talked to my colleagues in the Treasury. Yesterday, for example, I talked to the Governor of the Bank of England. We take our responsibility to inform the economic debate very, very seriously. And Patrick and Claire Lomadelli, the Chief Economist in the Treasury, have been involved in some joint discussions on this, on many of the key issues, for exactly the reasons you're implying. These are very difficult decisions. We have no illusions. There are health disbenefits to the economic things. There are massive economic disbenefits. None of us are under any illusions. This is really, really problematic. We're choosing between bad choices, basically, and that none of us should shy away from that and pretend that that is not the case.
And so again, just to be clear, on SAGE is not the place this happens. There are other places in which this integrates, and as Chris has said, we're involved in discussions where we will be presenting some of the health and other aspects, and others will be thinking and presenting the economic aspects.
So you present the health aspects to an economic committee. There's no presentation of the economics to the SAGE committee.
Well, there is an economic, for example, the paper that was referred to, I think, by Mr. Stringer earlier on, which is a fairly weighty document. That's got economic analyses within it. But what SAGE is good for is doing a kind of formal review of all the science from the different disciplines. I think it would be very dangerous if a group of scientists started trying to make economic pronouncements. It is, however, important that the economic elements are integrated in policy in the end. It is absolutely right.
Thank you.
I understand that. It's just the answers aren't particularly clear on where the economic debate comes into it. Can I just ask, Professor Andrew Hayward, who I understand is a member of SAGE, said on Radio 4 this week that the 2-week circuit breaker in September would have saved thousands of lives and would have clearly inflicted substantially less damage on our economy. Do you agree with Professor Hayward?
Who's that to,
Sir Patrick?
Sir Patrick.
The advice in September was about a circuit breaker with the intention of driving the numbers back to how they were in August, going back to the discussion on test and trace, because then that means you've got the greater chance of test and trace being effective, and therefore that takes more of the load of managing the disease, and you may have to do fewer in terms of other non-pharmaceutical interventions. So that's the logic behind that suggestion, and I think that's what Professor Hayward is reflecting in that comment.
Thank you.
So you do agree?
Well, I think it's a logic that if you can drive something back down to very low levels, you get a bigger return for test, trace and isolate, and it can carry more of the burden and less other measures are required.
So yes, Professor Whitty, just very quickly, do you agree?
Needs to be the last one, Darren.
I think this is. I need to be careful, not to give a kind of. I'm trying to give an answer which is actually both helpful but not falling into the trap of being a kind of yes-no thing. It's not a yes-no thing. You've got to think what if my economist friends would call the counterfactual on this is, and what is actually realistic and possible. Different things will have different effects at different times. I'm very cautious about ever saying, well, if we just did things differently in a slightly different way at a different point in time, where there are a whole series of imponderables you don't know, the following would definitely have happened as a result. I think we should be really cautious about that as scientists. I think we should be humble enough to realise there's a lot of uncertainty in these things.
Thank you very much indeed. I'm going to go to Aaron Bell and then Catherine Fletcher.
Thank you, Chair, and thank you both for appearing today, and indeed before this committee in the past and all the other select committees you have appeared in front of. It's been very helpful for Parliament. You said earlier your best estimate of R right now is still above 1. I wonder if either of you would comment on the King's College Zoe report this morning that they are now estimating it is at 1.0 across England, and that's obviously before we've gone into lockdown.
Well, we get different estimates of R from different places, and you'll know that the REACT study from Imperial from end of October suggested that the R was 1.6, I think, across the UK. One of the reasons that we have the SPIEM group do what they do is they try and integrate the values from different places and come up with an overall estimate of R, taking into account ONS results, REACT studies, Zoe app and so on, and look at the data that they see as well. So we'll expect a new updated R from the SPIEM group, which will be published on Friday, and we'll see where that is.
Okay. the modelling, and our colleagues have already spoken about the PHE report, seem to be based on an R of between 1.3 and 1.5, yet the government had already published on Friday before those slides that the current rate was between 1.1 and 1.3. So again, to ask why that wasn't reflected in the charts that were presented to the nation on Saturday, that the current R was below that was being driven, driving the charts that you were showing the nation.
Well, it was an assumption in that one graph. It wasn't in the 6-week projections. The reasonable worst case scenario is based on an assumption of an R between 1.3 and 1.5, getting potentially 10% worse over winter, and that is how you construct a reasonable worst case scenario. You put a series of assumptions in and say that could happen, and what would that look like? So that is what those scenarios were projecting. The 6-week projections were based on what we're seeing now.
Thank you. You mentioned the reasonable worst case scenario, and obviously the fact that we were proclaimed to be above that is what seems to have driven the rapid change in policy. Is the leaked version of the reasonable worst case scenario from the 30th of July that was published in The Spectator, is that accurate?
Well, the reasonable worst case scenario is a document that's owned by the Civil Contingencies Secretariat, yes. And I think it's for them to respond to that. We model what the Civil Contingencies Secretariat see as a reasonable worst case, and that's then modelled by the SPIAM modellers.
So SPIAM must have had input into the reasonable worst case scenario.
Yes.
What therefore explains the what David Spiegelhalter, to quote him again, the odd plateau in October in that reasonable worst case scenario. The case rate, the infection rate in October was shown as being perfectly flat in a worst case scenario, which I can't equate with either the meaning of reasonable or worst case.
Well, again, it was the assumptions that were put to the modelling group to model as to what that might look like, and there would be people at that time who thought that reasonable worst case scenario was excessive, and there were others who would think it's not. So one of the challenges is coming up with a reasonable worst case scenario that's both reasonable and worst case, and I think that one got exceeded in terms of the speed at the upswing. We still don't know what shape this is going to be, and it's quite plausible that as R comes down further, as we hope it will, not only with the measures in place but also with any new measures put in place. If the R were 1, you would reach a plateau. That's what you would see. Numbers would effectively stop at that level for quite a long period. And that's why it's quite important not to end up sort of fixing it at a high level, because then you've baked in a very large number of hospitalisations and deaths for a long period.
No, I understand that. I guess, fine, given that we all know it's a respiratory disease and we expect it to be seasonal, I can't quite understand how, even with a heroic assumption about what government intervention might do, that October infections were forecast in this reasonable worst case scenario to be static throughout the month, whereas we all know they've actually been doubling on an approximately fortnightly basis.
Well, can I just make a comment that none of us have been through this virus at this time of year, so I think how we can know exactly in advance what exactly the different seasons are going to do. I think let's be a little bit cautious about our own ability to predict.
Okay, thank you, Professor Whitty. In SAGE's assessment on the 21st of September, looking at non-pharmaceutical interventions, it forecast there could be up to 3,000 hospital admissions by the end of October. Per day. The figure on the 28th was 1,442. So again, I find it very hard to square those numbers. It was half as much as you potentially forecast as recently as the 21st of September, with the idea that we're suddenly above a reasonable worst case scenario. Could either of you comment on those numbers?
Well, they were from the modelling group then to sort of look at the interventions, and yes, at that point the view was that was going to breach the reasonable worst case scenario. At that point, that was what was predicted, and what you're really getting at, which I think is entirely reasonable, and point that I made right at the outset here, is that as you look for longer term projections, the numbers are bound to be wrong in one direction or another. I mean, they're almost bound to be wrong in one direction or another. As you look for the shorter time periods, you can get much more confidence in that, and the next 2 weeks you can have some degree of confidence you're probably going to be about there or thereabouts. Over 6 weeks, as say, they performed reasonably well. When you go beyond that, you start to have uncertainty, and of course that's when you have to rely on data, and it's a changing baseline because measures have been introduced since that document which have undoubtedly brought things down. And to echo what Chris has said, there have been heroic efforts from people across the country actually to adhere to some quite difficult things that have brought levels down, and that's been important to get the R, which would naturally want to be at around 3, down to somewhere between 1.1 and 1.3 at the moment.
Thank you. I understand the point you're making. Modelling is difficult, forecasts are difficult, particularly ones about the future. The hospital data is obviously what's driven the decision to go into lockdown, and I presume you would agree that we really need to be focusing on those admissions data, the over 60s admissions data and so on. But again, just to go back to the same point some colleagues made about the public presentation of that, the slide you showed on the hospitals, which did actually include my local hospital, the Royal Stoke, on it, that was only the top 29 hospitals in the country, and it was put out to indicate that a number of hospitals were over capacity. But what proportion of hospitals are actually above where they were in the first wave at the moment?
At this point in time, quite a small proportion. What I said and what was on the slide, I have to say, wasn't an absolutely ideal slide in my view, but was from the point of view of being seen on the TV, having sort of seen it replayed, is that those were just hospitals which at this point in time had 100 COVID cases or more. And my point about that was you move from, you've got 100 to you're now about half where it was to, in sequence, a point where a small number of hospitals at this point, but it'll be an increasing number of hospitals, have actually exceeded what they were at the peak. And it was clear from that slide that the number at this point in time is small. And what we're trying to do is try and keep it that way, to get to a situation where a very large number of hospitals are actually exceeded the first wave is exactly what we're trying to prevent.
No, I understand. I guess, you said yourself it wasn't an ideal slide. The whole set of slides there was an avalanche of data, and I just wonder whether either of you had any reflections on whether that was an appropriate way to make the case you were making to the nation at large, whether simpler, clearer data would have been more helpful.
Very succinctly, Mr. Patrick or Professor Whitty, any?
Well, I would always like to get things simpler than they were and clearer than they were. That would always be an aim, and clearly some of those slides are quite complicated, and it is a very complicated data picture.
Yeah, well, this committee keeps on telling us to publish more data, and then when we publish more data, you say you publish too much data. We do our best, and we accept that there is no perfection in this.
Touche. I think Catherine Fletcher is next.
Thank you, Chair. Gentlemen, thank you for your time today, but also for your service. I'm sure it's not been an easy few months. Can I just thank you for the acknowledgement that you've made about the efforts that have been going on in Lancashire, Liverpool, Greater Manchester and other large parts of the Northwest to keep that R rate down. It's been a difficult few weeks. And my question to you is basically on their behalf. So they've been doing lots of work. There's quite a lot of people saying the existing tier restriction systems hasn't worked, and therefore how can we believe that a lockdown is going to work? And I wanted to maybe dive into the behavioural side of the modelling. There was talk that we had underestimated the levels of compliance in the original lockdown, and I wonder whether we have overestimated levels of compliance in the slightly complex local restrictions that we've been working under the burden of up in the north of England. So do we think we understand how the people complying can help translate into defeating this virus through those models?
Shall I have a first go at this, and then Patrick may want to talk about the social science more widely. But what I have the privilege of doing, and it really is a privilege, is talking to colleagues, particularly the directors of public health, who are just remarkable across all of the north of England and the Midlands, but also local authority colleagues on a regular basis, and get their idea about how people are adhering to what is being recommended, and first in guidance and then in some cases in law. And I think, across the board, my reflection is the great majority of people, and this is reflected in all the polling and a variety of other things, the great majority of people both intend to stick to the rules and do stick to the rules to a remarkable degree. And to go back to Patrick's point, were that not the case, we would be in a massively worse place than we are at the moment. My expectation is R would have shot right up if people are not massively reduced the number of people they have contact with, really stuck to all the things we need to do in terms of individual actions they can take, the hands, face, space actions, and done a huge amount in businesses to try and make them COVID secure. Without that, we would be in a very, very difficult place compared to where we are now. So it is a huge tribute to the people that you represent and more widely in the country that we are at the moment. And the fact that the North East has managed to flatten things, that things are, I think, coming down, although not quite fast enough, in Liverpool, Merseyside more widely, and so on. These are really because people have done a lot more. And it's very easy to get a couple of photographs in the newspapers that imply that widespread flouting of the laws and guidance, actually that is not the reality on the ground that I'm having described to me and when I go out and about that I see in places like Morecambe or Blackpool or whatever it is.
Well, just to say, I mean, first of all, you're absolutely right to raise the point that these interventions do work. It's not that they don't work, they have an effect, and you can see that in terms of the R having come down a bit. So there's no doubt they work, and they work because people have adhered to them. And if you go back to the first wave, it's very clear that in the modelling, the admissions to hospital actually track very, very closely to a good adherence model. So people really did, and I think the simpler things are, and the more people are engaged with the information, the more likely it is we get to good adherence.
Catherine.
I'm glad for those comments, because it's difficult to not see your family and hug your relatives and worry about what's going to happen at Christmas. So, yes or no, is this lockdown going to work?
If people adhere to it in the way that I expect they will, it'll reduce R below 1, in my view, in the great majority or all of the country, and that will pull us back in time, and that will make a huge difference. I think the word work, I think what I wouldn't want to imply is that suddenly that means that COVID is over as a problem. This is a long haul, and I've said repeatedly, and I think people basically broadly accept this, that we need to see this through winter. This doesn't mean we need to stay in these measures through winter, and I want to be very clear about that, but we will need to be doing things that keep the rates down, which are for exactly the reasons you're saying, at every level, even well short of the lockdown, are very much not what we're wanting to do. People have been incredibly good at adhering to it. And going back to a point that was really from the beginning of this hearing, young people who everybody gave a whack at, they have brought the rates down in their own age group by their actions. That has been remarkable. And I think we should really, we should celebrate that and, mark the fact that they have done this on behalf of society.
I don't think I've got anything to add to that. Okay. I agree entirely with what Chris has said.
Catherine?
Thank you both, gentlemen. Thank you, Chair.
Just on Catherine's point, do you expect us to be able to lift these restrictions on the 2nd of December?
The Prime Minister has stated that that is what he intends to do.
Does your modelling predictions based on these measures being taken, we've talked about what would happen if they didn't, based on these measures being taken, would you expect to recommend that we can...
So the decision as to whether to lift the restrictions on the 2nd of September is not a modelling decision. It is rightly a decision for ministers and Parliament. So that is, in a sense, what I'm trying to do is do exactly what at the beginning I said we must do, which is we must provide technical data and helpfully interpret it as best we can. But it is for ministers and for elected politicians to make those sorts of decisions.
Well, you must have modelled the prospective impact of the measures that are being recommended to the House of Commons and the House of Lords tomorrow. If we adopt these measures, if we vote for them, will they succeed according to your best ability to forecast this? Do we think that they've got a good chance, a reliable chance of succeeding to the point that they can be begun to be lifted on the 2nd of December?
I think that the aim of this is to get the rates down far enough that it's a realistic possibility to move into a different state of play at that point in time.
Carol Meyer.
Thank you, Chair. And can I say to start with, more data is better. I think all of us on the committee would agree with that. And it's up to people how they interpret it. But as people who advise the Prime Minister, are you confident that your advice is actually being heeded and acted upon?
Well, I'll have a go at that, Chris. And then, I mean, our job is to make sure that the science advice that we pull together is heard and understood and can inform, therefore, decision making. It's clearly not advice that turns into the decision. And so in terms of, do I think that the advice has been well put together by scientists who know what they're talking about? Absolutely. We've got great people working on SAGE, many of them, including from all of the devolved administrations as well. I think the advice has been clearly presented, and I think it's been understood. Now, as we've alluded to several times during this, there are many other factors that need to be taken into account, including economic analyses, including other societal considerations that must ultimately come into a decision. So I don't think it's sort of linear to say, you know, has the science advice been taken and turned into action? I think that's a decision for ministers.
I talk to my fellow CMOs from the four nations, very regularly. I mean, often on a daily basis, and I'm very confident that in all four nations, and that therefore represents multiple parties. If you look across the four nations of the UK and then local authorities, that people are listening to medical advice in a way which has not happened for a very long time, and that's for a bad reason, which is you've got a pandemic on our hands. But I don't think I'm sensing from my fellow CMOs, from the Directors of Public Health, that they're not being listened to at all, actually, in any of these environments. I'm not making a point about any particular administration or any particular level of government. What therefore then happens is politicians have to take difficult decisions that integrate the economic and societal aspects as well, which is as it should be.
So we've seen across the world, actually, those that have taken action quickly have seen a less of an economic impact. So I don't really want to get down the line of it, but I mean, why are we at the moment among the worst in the world at dealing with this pandemic?
Patrick?
Well, I think there's a long way to go in understanding how this all plays out across different countries. We've clearly had a big infection, for sure. We got seeded with multiple introductions in February and March, and we had a very big nationwide pandemic, whereas I think many other countries ended up with quite localised outbreaks. We ended up with one right the way across the country, so I think that's been a big problem. And I think all sorts of reasons to do with population demographics and other things have played into that as well. I mean, we're broadly similar, of course, to other countries in Europe, not all of them, and we know that some that have had very well-funded and well-structured public health systems, like Germany, have done very well. I still don't really understand why. Even they don't really understand why they're different. So I think there's a long way to go to understand why there are differences. But your general point, which is that I think what's become absolutely clear, is that it's important to go quite early and to go quite significant in terms of reaction to this. And it's a problem because, of course, at the time you need to move, the problem isn't evident. And that's exactly what we're facing at the moment.
Carol?
But Sir Patrick, if I could continue, then you made your grim prediction, scenario, whatever you're calling it, and can actually take you to task slightly on that, because you tried to make a difference between what is a scenario and what is a prediction. And then when answering questions to my colleague Garen Bell a few minutes ago, you referred to your own prediction, not scenario. So I think it's difficult for members of the public and indeed politicians to understand the difference between predictions and scenarios if these words seem interchangeable. But on the 21st of September, you've referred to that already this afternoon, you made this prediction stroke scenario. And yet here we are over 6 weeks later, and it seems as though we're only now starting to pay heed to this. Have we learned no lessons since March?
Well, that just to be very clear, on the 21st, what I said was very clearly not a prediction. It was a model saying if it doubles, this is what it could look like. It turns out that it does look like what we said, not because it doubled, because it started from a higher baseline, but those numbers did turn out to be just about exactly where we ended up in October. And I think that's exactly the point. These things are things you need to take account of when you see them. They're there.
So having seen what happened in March, why were we not acting on the 21st of September? Why did we wait till the 31st of October before we saw England taking any action?
Well, I think the choices, as both Chris and I have said, are difficult ones for ministers to take. They have to take into account many other factors, and the fact that we're having this rather difficult discussion today around what may happen over the next few weeks and whether or not we've got action required in order to bring this back under control, whereas I think everything we're seeing says yes, there is a big problem that needs to be dealt with, shows how difficult it is to make these decisions. And all I would reiterate is...
How regularly between the 21st of September and the 31st of October were you giving this advice to government that we had to take action?
I think that we've been consistent all the way through that there is an increase coming, and that therefore if you want to do something about it, the increase doesn't go away on its own.
So how many times have you given this advice?
Well, I think probably Chris and I have been in meetings virtually every day.
Thank you, Chair.
Thank you very much indeed. We're now going to go to Zara.
Thank you, Chair. So the proposed set of restrictions will see education institutions staying open. We've seen data from the Office of National Statistics showing that the biggest growth rate is amongst secondary school pupils, and the National Education Union have analysed these figures, showing that virus levels are now 9 times higher among primary school pupils and a shocking 50 times higher among secondary school pupils since the start of term in September. On one particular day, the 15th of October, the Department of Education estimated that 412,000 state school pupils weren't at school for COVID-related reasons. That's a huge number. And we know that while the virus doesn't badly affect children themselves, there is clear evidence of transmission into wider community, staff and parents. So my question is, as long as schools are open, do you believe that the R rate will fall below 1, or do you predict that we may have to have a longer lockdown purely because schools and universities are staying open?
Do you want me to first go there?
Why don't you comment, because you...
I'll comment first, because the Chief Medical Officers did a joint, for the 4 nations, all the CMOs and all the DCMOs did a joint statement on this because they wanted to be really clear about where they stood on it. I would divide the problem into 3 sets of problems. The first problem, rightly, the most important, is children. There is really clear evidence that not being at school is a big disadvantage to children. It's particularly a big disadvantage to disadvantaged children. It has mental health impacts, and that will be true for all the children who are not at school. Set against that for children, although they do catch COVID, they usually catch it much more mildly. Severe disease is really substantially less than even for young adults, and deaths are mercifully very, very rare, not completely none, but very, very rare. So on balance of risk for children, the balance of risk in our view, professionally, is firmly for children to be at school. The second set of questions, which are legitimately asked, are what are the risks to teachers? And that is a fair question. The risks from internationally, although the data are not absolutely overwhelming, but all the data, including ONS data, do not imply that teachers are a high-risk occupation, unlike, for example, social care workers, medical staff like myself, and others who do, when they go into work, they have an increased risk. The rates, if you look at the ONS rates, they look almost identical to the communities from which they are drawn at this point in time. Now that, data can move on, but at this point in time, that would be my judgment as a public health epidemiologist. And then the third bit is the question about R, and here I think we have quite a lot of consensus that the rates, the transmission in primary school children probably is a relatively small contribution. It won't be zero, but really pretty small. I think there's more debate around the questions around secondary school, particularly older secondary school children, so 17, 18, 19-year-old. But in a sense, then there's a societal question. Given the huge benefits to children, what is the right balance for society? And that's, in my view, fundamentally a political question. But the reality is, in our view, that the benefits to children are really clear.
Zara.
Thank you. I'm just going to move on to university education. So on the 21st of September, SAGE advised that higher education tuition should move online or distance learning for first term until prevalence has fallen. The proposed measures that come into force from Thursday advised increased levels of online learning where possible. So what is the effect of transmission of higher education institutions remaining open for face-to-face learning, even if that is partially?
Well, I think all of the things that are open carry some price on R, and so that's just a fact that the more contacts you've got, the more interactions you have, you will increase the pressure on R. I think the universities have done a really, really good job of trying to get on top of this, and you can see levels decreasing across that age group, both outside universities and inside universities. That is an age group where we see the numbers coming down. I think many of them have really done a lot in terms of trying to test in their own institutions. They will have to make their own judgments around what is a course that's best delivered face-to-face and what can reasonably be done online, and many of them have gone to very large lengths in order to make that happen. And they've also gone, I think, a long way in terms of making sure that they've got appropriate ventilation in rooms and space and so on. So I think the universities are handling this in a very mature way in order to try and make sure they get on top of this. And as I say, the evidence is that amongst that age group, things are coming down a bit in some places.
Sorry. Thank you. In Coventry, specifically, as my constituency is there, the Cannon Park area and the university area have seen the highest concentration of cases, and that has been the case for some period of time. There have been around 119 university COVID outbreaks so far this term, and figures from the University and College Union say that there have been more than 35,000 student cases since term began. In what scenario could we see universities being told quite firmly that they must move all non-essential in-person teaching to online? And what would you say to students who feel like they're locked in their university halls or in private accommodation, who are essentially trapped and want to go home before we move into a national lockdown or just before Christmas?
Well, I'm going to try and stick to the science on this. I mean, there are lots of questions in there about, how universities want to run and what politicians may want to advise. But in terms of the impact, as I say, I think the universities have actually done a rather good job of making sure that this is damped down. I do think there's a real issue about two things. One is the quality of education people are getting, which is important. I think that needs to be, in some cases, face-to-face. That will be important for some courses and some approaches. And it is obviously important that the mental health and other aspects of student life are properly considered, and it cannot be nice to be locked in a place for isolation. And I know universities are thinking about that very hard.
Sarah?
Thank you, that's all from me.
Thank you very much indeed. Mark Logan, please.
Thank you, Chair. Sir Patrick and Professor Whitty, I was just wondering, what advice does SAGE give to government in making decisions where evidence is weak, for example, on the closing of places of worship?
Yes. Well, what we've said in terms of looking at a package that might get R below 1, and that's really what the aim is that it has to be a package. So you have to think of this as a series of things that interrupt individual activities, but also as a whole will have an effect on contact and interaction. And the danger in trying to then pick apart each one, and when you get down to the ones towards the lower level, where you might say, well, this doesn't make much of an impact on its own, is that you keep cutting things off and then you end up with a suboptimal package that doesn't get R below 1. So you're right, we haven't got good evidence on the exact value of each intervention on R. We produced a paper suggesting what that might be in different areas, but really said, look, this is not a very exact science at all. And therefore, I'm afraid it's a rather blunt instrument, and it's about making sure that there is a package of measures which together has a chance of getting R below 1, because shrinking this is the key thing.
Mark.
So Patrick, can I just ask, I mean, since the 4th of July, whenever we've had the kind of national relaxations, these last few months, how much transmission do you think has taken place within places of worship? Is it significant or is it quite negligible?
I don't think we have good data to answer that with any degree of certainty.
I'd add just one additional thing is that there is some very weak data to imply that even if the place of worship has been incredibly good about being COVID secure, by bringing people together, people can congregate outside and do things which actually do lead to transmissions. But these are very variable, and I think a lot of this is anecdotal, so I think we should be a little bit careful about putting that out as this is a scientific fact, this is just reported behaviours.
And there are reports of outbreaks, as we know, and particularly in the US there have been several reports of outbreaks from churches, and there are environments, where you're bringing together people who might not normally come together in internal environments, and so on. So there's an environmental aspect of this, but we can't put an exact number on this for sure.
So, well, when I'm looking at it from my constituency in Bolton North East's perspective, we've got roughly 59,000 Christians, around 11,000 Muslims, and my constituents have been emailing me and saying that they feel that the government sees faith as nothing more than an optional social activity. What would you say about that?
I would say that we're not the right people to advise on that. It strikes me as a theological question.
Mark?
Well, I mean, I think it's quite important, because if we want people and constituents right across the country to actually adhere to government's advice and the science, that we make a convincing argument. And when I'm looking at the SAGE advice from, I think it's the MPI paper of the 21st of September, it doesn't make a hugely convincing argument about the R rate in relation to places of worship. So I'm just wondering, is there any way in which, you've talked about a whole package, but when it comes to places of worship, would you advise potentially the government to reconsider on this one example?
We are trying to avoid a situation where we're constantly double guessing at a micro level what individual government decisions are. What I will say though is that all the faith communities of the UK have been extraordinarily responsible in the way they've tried to address this. And I've spoken to faith leaders from every faith that for which it's possible to actually find a faith leader group. And in every case, they have been very much of the view that this is very regrettable for everything they're trying to do, but at the same time they absolutely see the need to put health at a very, very strong premium on the need to protect the health of citizens widely, of all faiths.
Okay. Mark?
Thank you, Chair. Thank you, gentlemen.
Thank you very much indeed. Just on this theme, it's not a theological question when it comes to exercise. As Chief Medical Officer, you are someone that promotes the importance of exercise, not least in being fit and well in the face of COVID. That it continues to be the case. Presumably, exercise is something that we should be taking.
We're it's very, very much something which I would strongly say to anybody is that taking exercise, whether indoors or outdoors, of any sort, is something which people should try and promote at all stages. And actually, it's important that people take extra care that they build it into their day during lockdown. In fact, the data would imply that quite a lot of people have done more exercise in lockdown than they have normally, but other people have not. And exercise as a whole is something which we absolutely would want to promote, and it's one of the exceptions for going out of your home is exercise for exactly this reason.
That being the case, Sir Patrick, are you aware of any instance in which a COVID infection has taken place between children playing football out of doors?
Not that I'm aware of, but there may be evidence. I haven't seen it.
Given what Professor Whitty said about the benefits of exercise, it's the case that children's sports teams outside school settings are now not allowed to meet. This seems perverse given the importance of exercise, and as you've told this committee before, the very low incidence outdoors of transmission. It seems to me that this is a matter that isn't theology, this is scientific advice. Is this something that you could further advise the government on? Because there's a lot of concern amongst children's sports teams across the country.
Well, I think we've been very clear as to where we think the areas of transmission are most likely to be, and we've also been very clear that an entire package which takes into account everything, including interactions around events, become quite important. So it's not just the event itself, but what happens in and around it. And then it's for policy makers to decide what policies they want to adopt on the basis of that.
But did you advise that children's outdoor sports should be banned?
As Chris said, we just don't go down to that level of individual activities.
So who does? If you're the chief scientific advisor, the chief medical officer, we've talked about the importance of exercise and fresh air, yet a decision has been made to suppress children playing sport outdoors, and it doesn't benefit from your advice. Who's advising the government on this? Who's telling the government what to do?
Well, they've had advice from us in terms of the general principles and some of the areas, but as I say, not down to individual specific activities like that. And I think the same is true on the medical side as well.
To be honest, I think it would be deeply unhelpful if we then started to try and unpick really difficult packages which policy groups have put together. So I think this is a difficult balancing act across government. We fully understand that, and our job is to give the broad advice and then leave it to those who have to integrate the various elements.
I do understand that, Professor Whitty, but part of our role as parliamentarians is to voice the concerns of our constituents, and the fact that there is a package that has been stitched together does not qualify for it to be exempt from scrutiny and understanding, and we might be helpful if we were able to think about these things before they are irrevocably stitched together. Now, this does seem to be an important one. You have advised, SAGE has advised in its assessment of what are called non-pharmaceutical interventions that for outdoor gatherings in general, there is a very small reduction in transmission, to the extent that, quoting from the paper, that the reduction in R is likely to be less than 0.05%. In the context of not just what you said to the committee, but the work that you do to promote health and exercise, is this not something that, notwithstanding what you said about the whole package, this needs to be looked at again?
I'm going to rather boringly repeat myself, which is, if Patrick and I end up trying to unpick quite complicated packages that have been put together, that way disaster lies for everybody. So what we have to do is give broad principles, which we have done, and that you accurately reflect some of the broad principles that are published in SAGE minutes. And then packages have to be put together, which actually are very difficult to do. And I think everybody who's doing this is balancing really difficult things. And I think it is not our job to make their lives even more difficult in these difficult balancing acts.
But how can MPs representing their constituents influence this if we can only scrutinise things that are too late to do anything about?
What I'm suggesting is that the people to scrutinise are those who are having to put together these very complicated packages. What I think it's stupid for us to try and do is try and act as a proxy for a process in which we should not be interfering at that level of detail. It would be very unhelpful to the process that we did set.
Okay, thank you. Lord Patel, finally.
Thank you very much. Good afternoon, Patrick and Chris. Nice to see you both. I'm an interloper from the genteel side of the palace, so my question, I hope, will be more gentle. I'd like to understand what your thinking is in terms of the metrics that you will be using to assess the effectiveness of the measures we are about to go into. You mentioned several times, obviously, admissions to hospitals, so that obviously will be one. And to follow on from that, when we come to the end of the period, whatever decision is made beyond that, no doubt we'll need to be thinking right now as to how, at the end of the period, we're going to maintain the transmission to be at low level, so we don't get back to the same scenario. So what would be your comments on those two aspects?
In terms of In terms of the measures, I think it's very important that we are in a much, much better position than we were first time round, with things like the ONS survey, the REACT survey, and the ability to actually measure infections in the community, and JBC and all the work they're doing. So I think we should absolutely look at infection rates. That's the way we're going to find out earliest what the effect is. I mean, maybe before that, contact rates may give you more information even earlier, but infection rates, hospital admissions will be a slightly lagging indicator. And then, obviously, unfortunately, there will be deaths, and they will be an even more lagging indicator. So, for example, if things worked almost instantly and you got the R down to 0.8 or 0.7, you would expect to see an effect on infections quite quickly. You'd expect to see an effect on hospitalizations maybe after 2 or 3 weeks. You may still see an increasing number of deaths over the period because they are lagging even further. So we've got to get leading indicators rather than relying on lag indicators. At the end of whatever happens there, I think it's going to be important to determine what the measures are that still will be required, and in order to keep R down. And I think, as Chris has said several times, we're likely to need degrees of social distancing and other measures over the course of the winter. It's only really come springtime and beyond when other things may start to allow some more relaxation as other things like testing improvements, vaccines and improved therapeutics might allow further restrictions. But I expect at the end of this there will still be need for some changes, and hopefully increased testing can come along first out of all of those interventions and would potentially help.
No?
Yeah, sorry. Chris, do you have any comments?
No, I agree with that.
You do. So, if the current measures are stopped after 2nd of December, then we will soon enter into a period of festivities where there's likely to be more likelihood of contact. What effect do you think that might have on the transmission? And what would be the measures, on the basis that we won't have vaccine or anything by then, that will need to be taken to keep the transmission rate low, below R1?
Well, the policy that the government have announced is that the aim would be ideally to move into a series of tiers at the end of that period. That's what the Prime Minister has said he's intending to do. And I think what we'll have to do is design those as to try and match the situation we see ourselves in at the end of this month. Epidemiologically, and you are quite right, Lord Patel, that the festive season for all religious traditions, and obviously they come at slightly different times, do have risks associated with them. There's no two ways about that. That's true for every religion. That's one of the reasons why festivals are held, and we'll have to work out ways in which we can advise people in a way that maximises their ability to keep to the essence of what is the festivity, but minimises the risk of transmission. And that we're trying to work that through at the moment. But how risky that's going to be, how far we can go down that path, will very much depend on what epidemiological situation we face as we head into December and towards the peak festive season at the end of the year.
Lord Patel.
Thank you both very much. And the burden on your shoulders enormous. And couldn't think of two better guys to do it. Thank you, Chairman.
Thank you very much indeed, Lord Patel. Just a question on what Lord Patel alluded to about the criteria for coming out of the proposed restrictions. Is it possible to imagine lifting the restrictions if the R is still greater than 1?
Well, I think that in a sense, the aim of the whole thing is to make sure that R is not greater than 1.
Mm-hmm. But if we get to the 2nd of December and R is greater than 1, does that mean that we can't come out?
I do think it is sensible to see how we go on this. I have quite a lot of faith in the adherence of the general public in a way that will lead to the R reducing. I really do not. That is what I anticipate. That's what all the polling and other data show. People intend to do this, and I'm expecting that the R will drop.
So you expect by the 2nd of December the R to be less than 1?
Yes. I mean, nothing is certain in this world, and it may not be absolutely everywhere, but my expectation is that over the country as a whole, that is what I would hope.
If the R were very slightly above 1, and the NHS were adjudged to be able to have the capacity to cope with it, given the importance of overrunning the NHS's capacity in this, would it be possible to contemplate that the infection could still be spreading, albeit at a rate that we could contain comfortably within the capacity of the NHS?
Well, I think that the problem we have here, Chair, is, and I'm making an obvious point to you, but we have almost infinite future scenarios as to what this could look like come the end of this month. And rather than try to sort of speculate on what almost, as I say, almost infinite numbers of them, which may well be regionally different, they may well have different stages of the NHS capacity being threatened and so on in different parts of the country. I think the sensible thing to do is to wait until we see the effects of this and then take a view. And I'm sure you'll be wanting to ask some pretty hard questions of the political leaders who are actually making those decisions as we get closer to that point in time. But I think, before we've even actually had Parliament vote on these, I think speculating where we will be in 3 to 4 weeks' time, I think is probably a little premature in terms of exactly the kind of questions they're asking about what plans should happen next.
No, it's not to speculate, but obviously in voting on these restrictions, many MPs may want to, their support may be contingent on having an idea as to how they will be lifted, and whether if they're persuaded that there is a threat to overrun the NHS, if that is removed, but nevertheless the R is still technically above 1, whether that will be a veto. I think they need to have an ability to interrogate that now before they cast a vote tomorrow.
I think the decision as to what the strategic goal is rightly a decision for ministers. And I'm making that point because we make it repeatedly, but it is important that we don't claim to be taking the strategic decision. The strategic decision is a ministerial decision answerable to Parliament and therefore to the people. The question about what we would do if R was below, let's say you could have a scenario where R was just below 1 but there's an incredibly high rate and very, very struggling NHS in one area. Another area R was actually above 1, but actually the NHS was a long way away from difficulties. Those, I'm not saying this will happen, I'm just saying there's a theoretical possibility. Those kinds of scenarios I think would lead to different responses from ministers at that point in time, and reasonably so. And I think my view is we could probably, Patrick and I suspect all of the people on the committee could probably paint 100 scenarios, each one of which is not implausible. There'll be varying degrees of plausibility, which should lead to different places. I think the sensible thing is let's see what the data where it finds us as we get through to the point this decision has to be taken.
Are you aware of what the strategic goal of the government is?
The strategic goal of the government is primarily to reduce mortality, but it's got much wider strategic goals, including protecting the economy, protecting society. There are multiple strategic goals, and they're the ones which actually you should ask ministers about.
Okay, Graham's room.
I think Professor Whitty earlier on that there were really remarkable directors of public health. I agree with you, and I think they've done a good job. And I think Sir Patrick said that it might have been you that there'd been a huge increase in the testing at a central level. I mean, both those things are true. My view is that the test and trace system would have been more effective had it been concentrated more locally. I would be interested in your view and whether you feel it's within your purview to give advice on that.
I'm going to, in a sense, emphasise the bit of my role which is Chief Medical Officer and de-emphasise the element which is Chief Scientific Advisor of the Department of Health and Social Care. So my point here is not a science point, it's an operational point in a sense. I think that as you rightly say, the Directors of Public Health and local authorities have done an absolutely amazing job throughout actually this. Standing this up from a standing start in the first wave, when actually, with the possible exception of London, there was quite a degree of similarity across the whole country, given that we had pretty much less capacity on testing and so on at that point in time, I think there was a strong logic to take a more national approach. But I completely agree with you that the capacity of local authorities, particularly on the trace and isolate element of test, trace and isolate, the capacity is there steadily to increase the ability for people to do things. And the question is at what rate and how. But your general idea that actually we should be, where possible, using local skills, I broadly agree with.
It's good to hear that. One of the problems has been communication from the central test and trace system. It's either been slow or the actual quality of information has been pretty useless. It's been very difficult to disaggregate at a local level or apply to individual situations. I think that's one of the arguments for moving it to a local area, but more generally it has been very difficult to get both information out of test and trace and out of the NHS at a trust level. Is that a problem you've had?
I firstly try and get as much information from as many different areas as I can, and then I try and disseminate it as widely as I can. And I speak to the Directors of Public Health on a weekly basis or a bi-weekly basis, and part of the aim of that is to try and pass on what I know. But you're absolutely, I mean, the whole system has, one of the things that Sir Patrick has made a real push on, and I completely agree with this, is not just the NHS, but the whole system needs data to flow more fully in every direction. That is in everybody's interest, so that everybody sees as much information as possible. And this is important scientifically, it's important operationally, it's important for public health.
And my final question, if I may, in answering a question about international comparisons, you mentioned in passing that some health services were much better funded than our health service. We come midway in the European pecking order. Had we had 6 times the capacity in intensive care units, and I realise it's a theoretical question, it's a hypothetical question, would our response have been able to be less dramatic than it has been?
Well, clearly if we had 6 times the intensive care capacity, there would have been more headroom. But yeah, you still would have had, of course, an enormous number of deaths associated with that. And so the question then for ministers and society is whether you're prepared to tolerate those numbers of deaths. But yes, it must be the case that with a larger healthcare system, you would have more headroom to avoid collapse of the system or get close to real pressures.
Thank you.
Thank you very much. There was a brief final question from Dawn Butler.
Thank you very much, Chair. And Sir Patrick and Professor Whitty, thank you very much for your evidence today and all the work that you're doing. And I'm sure that it is extremely frustrating being scientists and giving advice and it not always being the sole factor for decisions that are being made. I'm just asking your advice, really. Have you given any advice to government in regards to how Parliament works and the number of people that are currently in Parliament and how we operate?
Well, that's a straight factual question, and the factual answer is quite early in the epidemic I spoke to the Speaker and the Lord's Speaker, but most of this has been done with Public Health England giving the professional advice since that time.
Sir Patrick, anything to add?
No, I mean, it's a Public Health England matter, and maybe Health and Safety Executive as well. But just on the fact of frustration about the sole advice being science, I don't think it is. I mean, I think we absolutely recognise there are many other bits of evidence and important parts that need to come into decision making.
Thank you. Viewers will notice today that we are abundantly socially distanced in this room. Finally, Erin Bell had one, I think, brief supplementary question.
Thank you, Chair. Yes, thank you, gentlemen. It was just about the end of this lockdown period, projected end in December. Is it the case that going back to a tiered system as is proposed, do you think that would push R back above 1 in December?
I think that very much depends on the situation we find ourselves in and what takes its place, and that's 2 imponderables.
Right. I mean, the proposal at the moment is to go back to the tiered system we currently have, and if any relaxations will clearly push R back up again. So is there an absolute case rate that you'd want to see by the end of this lockdown period before you'd recommend relaxations? For example, would it be sub 200, given that the average in England is around 300 at the moment?
I think that the Prime Minister would probably want us to look at whether there should be variations on exactly the same tiering system as at the moment, rather than just assuming we would just revert to an absolutely identical one. I think there's a lot to learn, and in fact, the next 2 or 3 weeks we will start to see the effects of the tiering in an even more granular way than we've got to date, and I think we should wait until we've got that before we start to decide how best to use that in future.
Okay, thank you both very much.
Are you comfortable with the prospect that Wales may lift its restrictions whilst England is imposing them?
I am very strongly of the view that under the devolved settlement, what happens in Wales is for Wales. I talk to my Welsh colleagues regularly, but I certainly don't see that as something which I should interfere with in any way.
But if it's the case that there are different restrictions in Wales, reflecting no doubt different choices and circumstances there, is it reasonable for Cornwall, for example, or Devon, to have a different regime over the next 4 weeks than London and
Well, the whole basis of the last few weeks has been that there has been significant difference in contrast to the first wave, which was, as I say, pretty similar across the country in different parts of the country. One of the things that I think is been happening at the moment is because the R is in fact higher in some of the lower areas now, that difference is being eroded. So I think that's just an epidemiological point. But the settlement, the reality is the settlement for health is there is an English system and there is a Welsh system. And it is important that we respect the fact that those are separate systems.
So it's a reflection of the constitutional settlement.
It is a reflection of the constitutional settlement, exactly.
Epidemiological.
Exactly so.
But the point that Chris has just made, that the growth is actually faster in some of the low prevalence areas, is important because that growth isn't visible to people, and it comes back to the point that the tendency is to want to act when things are very extreme and you can see hospitals in real trouble, whereas actually there's a real merit in acting sooner to stop areas becoming high prevalence areas.
Indeed, but if I take the case of Devon, for example, there's been a rate of less than 100 infections per 100,000 population since the middle of October. That seems to have been relatively stable by contrast to other places. So I was interested in whether there was the capacity to have differences such as there is between the two sides of the border in England and Wales.
Clearly that has been the basis of policy for the last few weeks. And I think our worry in the southwest in general is that it's not just a matter of the rate, which is certainly higher than in some parts of the north now, but also the fact that the actual bed base and other issues mean that, in fact, the ability to constrain that is also different. So these things are it's not just about our numbers, it's also about where you find yourself.
Thank you. And very finally, there is a school of thought. There is something called the Great Barrington Declaration that I think you'll be familiar with, whose view, the signatories' view, is that there should be a different approach to managing this pandemic, such as the more perhaps aggressive shielding of vulnerable people. Do you model the prospective impact of different approaches, or is your work on SAGE exclusively focused on the lockdown and social distancing measures that we've been talking about today?
Can I have a first go at that, and Patrick might want to? I have no doubt that the people, the scientists and others involved in the Great Barrington Declaration feel they're providing a useful contribution, and I mean no disrespect to them in what I'm about to say at all. But I think that the basis of this, although it says some perfectly sensible things like lockdowns are very destructive, none of one can argue with that. The basis for this is, in my view, scientifically weak, probably flawed actually, dangerously flawed, operationally impractical, and I have to say personally I think ethically a little difficult. If I can just explain why that is, and then Patrick might want to say a little bit about how SAGE has viewed this. The biggest weakness in this is that it starts from the thesis that inevitably herd immunity will be acquired if you leave things long enough. That is not the case for a very large proportion of the most important diseases in the world, and all the ones I've worked on, you never acquire herd immunity, ever. You don't for malaria, you don't for HIV, you don't for Ebola, you don't for most of the things that come in from the front door of hospital. You just don't. It never occurs. So the idea that this is an inevitable thing, which I think is a fundamental tenet to this, is simply incorrect. We do know that with this particular infection, that you can get some degree of immunity early on. I think that's reasonably clear, but we do not know how long that lasts for. And you'd have to get up to, even if it could be achieved over time, and people maintain that immunity for long enough, you need to get up to probably 60 to 70% of the population, which we are a very long way short of. And so, for all of those reasons, I think that that bit of it is basically wrong. The second bit, which is, I think, problematic, is the next assumption is that you have what they call focused protection, by which they mean identifying all the people who are vulnerable and keeping them out of the way of anyone who might have the disease. That's theoretically a perfectly attractive idea. Practically with this disease, which is a huge force of transmission, where you can catch it from people who don't have any symptoms, and which is highly transmissible and is everywhere, the idea you can do that and do it for year after year is simply impractical. Everyone has looked at this, and we've been asked this multiple times, and Sage has looked at this, and Patrick might wish to talk about how Sage looked at this. Says what a great idea until they look at the practicalities. How are you going to look after people in nursing homes? How will you look after people in hospitals? How will the elderly meet their grandchildren? So it is then, secondly, practically not possible. And thirdly, it would make an assumption that very large proportions of people, numbers of people, would inevitably die as a result of that decision, because you'd have to get all the people up to that 60% naturally infected, and in something which has got a 0.5 to 1% infection fatality rate, that means a very, very large number of people, if you think of the 60% or 70% of the UK population, would inevitably die as a result, unless you could achieve this perfect identification of everyone who's going to get ill, which you can't, and entirely isolate them for several years, which you can't. Other than that, it no doubt has some merits, but that's the reason why I'm really quite cautious of this, and I share therefore with the Director General of the World Health Organization the view that given all of those, to have this as an element of policy would be ethically really difficult. There is only one place you should be thinking to get herd immunity as an element of policy, and that is when you have a good vaccine. And that is the one situation where it genuinely makes sense, but we currently don't have one. I hope we will get one soon.
Thank you. Patrick?
Yeah, well, we published a paper outlining exactly that a few weeks ago as the argument as to why this really is not a good idea and why it's got some fatal flaws to the argument. Two others that I would add. I mean, first of all, I completely agree that you get to an attempt to herd immunity through vaccination if you can, but that's not always possible either. Two other things just to bear in mind. It's not that people under the age of 70 do not die from this disease. You do get deaths, and so even if you were able to shield totally, you would still see a significant number of deaths in younger people as it went through the population. And we also know that the long COVID syndrome causes quite a lot of problems for people, because you'd have a big burden from that as well. And the final point, just to build on something Chris said, is multi-generational households are a very real thing in this country, particularly amongst certain communities, and that would be a major problem. You would be essentially causing a big problem amongst some of the communities that are most hard hit by this already.
Thank you. So obviously with the exception of vaccines and perhaps you may say effective treatments as they come, that aside, there is no alternative to the set of measures, the types of measures that we've been talking about today, in your view?
So I mean, my view is clearly where we want to get to is medical countermeasures. There may be drugs, there may be vaccines, there'll be some combination of drugs, vaccines, diagnostics and other things. And I'm really confident, Chair, that we will get to that, because we've got to that with every other major infection. We are incredibly good at handling infections over time. The problem is till that happens, and none of us can know which ones will actually finally get through over the finishing line and when, and it'll usually be an accumulation of small advances that add up to a big enough advance that we can say, look, this hasn't gone away, but it's much, much smaller, we're left with these very destructive, very blunt tools. None of us would wish to use them. And if you could say then we'll never get a scientific answer, then you might say, well, okay, fine, it's never going to happen. But in fact, anyone who thinks about this would be very confident that over the next year, probably even sooner than that, we will have multiple shots on goal from science. So the situation will get steadily better, in my view, from the time that we get from early next year onwards. It will be a rolling through of the extraordinary scientific effort that is currently going on across internationally, the public sector, the private sector, all working on this. So I am very confident we will get medical countermeasures. What we have to do is hold the line until that point. And that's where, unfortunately, these destructive, economically and socially destructive tools are what we've got in the absence of anything else.
So difficult winter, but a bright spring.
Yeah, I think that's right.
Brighter.
And I think that there are some concrete bits to this. I mean, first of all, we've got one drug already that we know reduces mortality in patients who require oxygenation in hospital, and that's dexamethasone. There will be others that come along, so that's looking concrete. Second is testing technologies, near patient testing and things which are faster are here and now. They're beginning to happen. That will improve the ability to do that. Third is that the vaccine situation, we didn't know at the beginning of the year where we'd get to. There are now vaccines that produce good immune responses. Doesn't mean they're going to work, but they're on track. They're in late stage clinical trials, and we'll get the readouts. Those are all quite concrete things which are really pointed in the right direction.
Thank you. We're very grateful. This committee, with the Health and Social Care Committee, in its joint inquiry, is going to be taking evidence tomorrow morning with the leaders of the vaccines.